work to create a world
that's free of infectious diseases.
We work to make sure
that no infectious disease
is left unchallenged.
We discover, develop,
implement and evaluate
health solutions,
working alongside the most at-risk communities.
Doing so ultimately builds
a healthier, safer world for everyone.
We are the Kirby Institute.
So welcome to this, the 14th annual Brett Tindall Memorial Lecture. Welcome, and we're very honoured to have the CMO of Australia, Michael Kidd, presenting the Brett Tindall Lecture today. So this lecture is, so before we go any further, I'd like to acknowledge the traditional owners of the land on which we meet, the Bidjigal people, and pay my respects to elders past and present, and extend that respect to any Aboriginal and Torres Strait Islanders that are joining us here today. So this lecture is given in honour of one of the first employees of the Kirby Institute, Brett Tindall, who was born in 1961 and did his first degree at Cumberland College, and then was enrolled in postgraduate medicine at the University of Newcastle in what was then a very new course in medicine. But as HIV was breaking, he decided that he wanted to do research and work at the coalface, and left medicine and was recruited by David Cooper as one of his first research assistants. Brett's talent was rapidly identified by David, and he rose through the ranks at the Kirby very, very quickly and became one of the senior scientists and also the manager of the centre within a couple of years. Brett did truly extraordinary work in his short life. He made many seminal observations in those early days. One of those was that he, working with David Cooper and Basil Donovan and the general practitioners in the Darlinghurst area, put together the laboratory observations around seroconversion with the symptomatology that people were seeing, and made the first description of the primary infection illness, or the seroconversion illness, as it was then called. He then went on and made very important observations around a group of a group of people who'd been infected by a single donor, but who had not progressed. And they were called the Sydney Blood Bank cohort, and they were infected by an attenuated virus, or what was later discovered as an attenuated virus from which NEF had been deleted. But the original observations about the clinical state, the laboratory parameters, were greatly contributed to by Brett. Brett was involved in lots of other publications and lots of other research at that time when we were still learning a lot about the virus. But those two seminal pieces of work really demonstrated how Brett understood we should work. He brought together clinical data, he brought together the laboratory, and he worked with the community and the practicing clinicians to actually get a much greater understanding than other people around the globe about how this virus worked and affected people, and the parameters associated with the pathogenesis of the disease. And really, one of the reasons we have this lecture is because that way of working, of bringing together those different components that are often looked at in isolation, is, I hope, the way we work at the Kirby that way we have worked at the Kirby and how we will continue to work going forward, bringing together the laboratory, the clinic, and the community to make observations and to allow implementation of our research. Because of his dedication to the community, he was an early member of ACON and sat on a number of committees there, and in that representation was noticed by Jonathan Mann, who recruited Brett to a number of WHO committees. And through those WHO committees, Brett met Michael Kirby, and thereafter had a long-standing relationship with Michael, our patron. So Brett managed to complete an MSc and then a PhD, which was awarded in 1994. But Brett passed away that same year of HIV at a time when we were much less good at treating the disease. And so the first of these lectures was given by Fritz Grenzeven, who traveled all the way from Thailand to give this lecture. And we've had a number of other prominent people give the lecture since. So I'm now happy to introduce today's Brett Tindall lecturer, Professor Michael Kidd, who, as I said, is Australia's Chief Medical Officer and a global leader in primary care and a passionate advocate for equitable, high-quality health systems. He holds a joint academic appointment as Foundation Director of the International Centre for Future Health Systems here at UNSW, and a Professor of Global Primary Care at the University of Oxford. A general practitioner and public health researcher, Professor Kidd has dedicated his career to strengthening health systems, improving care for marginalised communities, and leading responses to pressing health challenges from infectious diseases to chronic conditions. He's also served as President of the Royal Australian College of General Practitioners and the World Organisation of Family Doctors, as well as being, in the past, the Executive Dean of the Faculty of Medicine, Nursing and Health at Flinders. Through all these positions, he has shaped the future health leadership both here in Australia and internationally. So I'd like to introduce Michael now. We'll have questions time for questions at the end. Michael, thank you very much.
Dear colleagues, thank you for the opportunity to join you here today. The chair is because I have a sore back. I've reached the age where my back goes out more often than I do. And that's just in case I need to sit down during the talk. I'd like to start by acknowledging also the traditional owners of the beautiful lands and waters where we're meeting today, the Bidjigal people, and I pay my respects to their elders, past and present, and recognise the enduring connection that Aboriginal and Torres Strait Islander people have to country, and invite us all to reflect on our shared responsibility to honour and respect this special place where we live and work and its stories. I also would like to acknowledge the people who make up the Kirby Institute. Thank you all for your extraordinary contributions to the health and well-being of the people of Australia and the people of the world through your research on the prevention, diagnosis, treatment, and hopefully elimination of infectious diseases. And thank you to the Director, Tony Kelleher, for inviting me to deliver this 2025 Brett Tindall Memorial Lecture. I'm very conscious of the importance of this lecture and the privilege of being invited to join the list of those who've delivered the lecture in the past, including national and global leaders in infectious disease research, in health policy, and in community advocacy. Tony's asked me to talk about health leadership and tackling health challenges, and it's a very broad topic, so please bear with me. But I can't start a talk about health leadership in this place without acknowledging a great health leader, the foundation director of this institute, dear friend to many of us, Professor David Cooper AC, who led this organisation from 1986 until his death in 2018. Now, as you probably know, David initially established the Australian government-funded National Centre in HIV Epidemiology and Clinical Research, more of a mouthful than the Kirby Institute. And then in 2011, the organisation was renamed in honour of the Honourable Michael Kirby AC, Australia's longest-serving judge and a passionate, vocal and highly respected advocate for health and human rights, and a friend to many people in this room. Michael, 2 years later, accepted David's invitation to become the Institute's patron. And Michael has sent his apologies for today's event. He is, as those of you who know him, of course, travelling, in this case to India, where he's currently chairing an arbitration process. David Cooper, through his wise and gentle leadership, influenced the careers of many of us. And through his leadership as a clinician and researcher, he impacted the lives of countless people affected by HIV in Australia and across the world. I was very fortunate to work closely with David and the then National Centre on a number of occasions, including having been invited by David to facilitate a series of national summits to assist the Centre in setting the national research agendas for research in HIV, clinical research back in 1998, in hepatitis C research in 2000, and in research looking at sexual health risks for Aboriginal and Torres Strait Islander people in 2001. Now, the lecture is not named for David, it's named for this man, another health leader, as we've heard, Dr. Brett Tindall. And Tony has shared some of the details of Brett's story, but what strikes me the most about Brett's story is how his life as a gay man living with HIV intertwined with his work as a researcher, as one of the first employees of the then National Centre. As we've heard, Brett worked with David and other colleagues on some of the very earliest studies on HIV seroconversion, on primary HIV infection, and on early antiretroviral therapies, work that directly impacted the clinical care that I was providing at that time to my patients and community, as it did impact clinical care being provided to people around the world. And as Tony has reminded us, Brett died from AIDS in 1994, just before the modern era of effective antiviral therapy. Michael Kirby and his husband Johan became friends with Brett, and Michael told me last week that Brett knew only too well what he was up against and how long he had to live without a cure. And he also spoke of the tragedy that if the topics of Brett's research on triple combination therapy had progressed more quickly, he might have been still with us today. I've spoken to some of those of you who also knew Brett and who shared with me not only the importance of his contributions to medical science, but also the importance of his impact as a person with HIV, who was also a researcher. He was a trailblazer in many ways. He was also described to me as having been swarthy, sultry, and a very sexy man, which I expect, I don't know if I'm allowed to say that, but I expect he would have been very pleased to have had me repeat that today. Now, I personally never had the opportunity to meet Brett because I didn't move up to Sydney from Melbourne until the end of 1995. Prior to that, I've been working as a general practitioner with the Gay Men's Health Centre based at the Victorian AIDS Council. Victoria was a little more conservative in those days than New South Wales. In the early 1990s, the Victorian AIDS Council nearly lost its funding for HIV prevention and clinical care programs because of outrage over this campaign called Two Boys Kissing. The campaign caused major ructions in the Victorian Parliament through, I quote, the use of public funds to promote an outrageous homosexual lifestyle agenda. It looks pretty innocent to me, especially with the benefit of times, but that was Victoria back in those dark days. Originally in Melbourne, we had our Gay Men's Health Centre HIV clinic at the back of a terrace house in Smith Street in Collingwood, which we shared with the main offices of Victorian AIDS Council. And in February 1994, on the night of the first Mardi Gras parade telecast by the ABC, our clinic was destroyed in a firebombing attack. We then had to move our service to the newly established Positive Living Centre, which was in Ackland Street in St Kilda. Always struck me as really odd that there was no media over the firebombing attack of the Gay Men's Health Centre in Melbourne, which said something as well. As well as my work as a GP, I was also working at that time as a researcher at Monash University, and I was completing my own doctoral research, which focused on the use of digital technology in HIV health education and clinical care in primary care. And there was very little interest in the primary care management of HIV at that time outside the group of GPs and primary care nurses who were delivering care. I remember I had an abstract accepted for a major family medicine conference in Philadelphia in the USA in 1992. And when I turned up to give my talk on HIV management in primary care, there was only one other person, an older man, sitting in the room. Well, I soldiered on and I gave my talk, and then I asked if there were any questions. And the sole member of the audience put up his hand, and I went, yes, you. And he said, that was a great talk. Can I ask you for a favor? And I said, for you? Anything. And he said, would you mind staying? I'm giving the next presentation. So I did. I listened to his great presentation and we went out to dinner and we became lifelong friends, which is kind of what happens in academia. Anyway, let's talk a little bit about leadership. I've been very fortunate, as Tony has said, to have had a number of leadership roles during my career, including elected roles as the president of the Royal Australian College of General Practitioners and the World Organisation of Family Doctors, and also leadership roles in a number of universities, University of Sydney, Flinders University, University of Toronto in Canada, Australian National University, and more recently here at UNSW and at the University of Oxford. Some of us spend our whole career in one place, and some of us like to move and share things around a little bit. I've also had a number of leadership roles with the Australian government, which included being invited to chair the HIV committee of the then Australian National Council on AIDS, hepatitis C and related diseases from 2000 to 2003, where I had the great author Dennis Altman as my deputy chair, and Andrew Grulich as a member of the committee way back then. And then in 2003, we got a new health minister in Australia, Tony Abbott, and the gay men on the HIV committee were all sacked. Dennis was incensed because he was replaced by a Salvation Army major. If you know Dennis Altman, imagine replacing him with a Salvation Army major, which he still talks about. Somehow though, Andrew, you flew under the radar and you stayed on the committees, so not quite sure what was going on there. Then in 2009, I was back in the good books. I was appointed by the then Health Minister, Nicola Roxon, to chair McBeavis, the National Ministerial Advisory Committee on Bloodborne Viruses and Sexually Transmissible Infections. And I served in that role for 6 years. The reason I got to chair McBeavis was because Don Baxter, who some of you will know, he was the CEO of ACON, he was asked by Nicola Roxon to come up with a consensus chair who all of the stakeholder groups would be happy to support. And after every single other candidate had been vetoed by one or more of the stakeholder organisations, I was the only person left standing, so I got invited to be the chair. One of the bonuses of chairing the McBeavis was that I got to work closely again with David Cooper and with other members of the Kirby Institute, including John Caldor, who had me on speed dial most of the 6 years, telling me what the Australian government needed to be doing about bloodborne viruses, which was very welcome. And then, as some of you will know, from 2020 to 2023, I served as the Deputy Chief Medical Officer with the Australian Government Department of Health and Aged Care during the COVID-19 pandemic, and worked again with many of you on initiatives to support ensuring ongoing care for people with HIV and other bloodborne viruses during the pandemic. And then in June this year, I was appointed to the role of Chief Medical Officer, which is undoubtedly the most important leadership role I've had in my career. Now, as some of you will know, the role of the Chief Medical Officer, or the CMO, was established 42 years ago in 1983, which was the year that I graduated from medical school. And my responsibility as CMO is to provide expert medical advice to the Australian government and to the Department of Health, Disability and Ageing across the full range of public health and clinical care issues facing the people of our nation, and to draw on the expertise of others when my own knowledge is lacking or incomplete, which of course is in many, many areas. So one of the most important things about being the CMO is to have lots of phone numbers on your phone, people that you can dial a friend when you need advice. But I was surprised to learn when I became the CMO that I am the first general practitioner ever to be appointed to the role in 42 years. And I hope I won't be the last. I'm also the first male CMO to be married to another man. And my husband, Alistair McEwen, and I, we were married in March 2018. A few of you were at our wedding, shortly after the amendments to the Federal Marriage Act on December the 9th, 2017. So to everyone who voted yes, thank you. Thank you for doing so. I imagine this is a room full of people who voted yes. Finally, as some of you may also know, I'm also told that I am the oldest person ever to be appointed to this role of CMO, which doesn't thrill me nearly as much. I'm not going to tell you how old I am, but I've just had my free shingles vaccinations, so that probably gives you a clue. Now, when talking about leadership with medical students and registrars, I often ask them to think of a leader who inspires them, and then to describe the qualities of that leader that they most admire. It's a really good exercise to do with your own students. And I want to share with you some of the more popular leaders among students. This is Mahatma Gandhi, of course, and one of my favorite quotes from Gandhi is that honest differences are often a healthy sign of progress. This I find really helpful in medical politics, because often you have warring factions who both want to achieve the exact same thing. What they disagree about is the way to get there. And Gandhi reminded us that recognizing these honest differences and talking about them can be a very important, healthy sign of progress. This is the great Nelson Mandela. In his autobiography, he wrote that it's better to lead from behind and to put others in front, especially when you celebrate victory, when nice things occur. But you should take the front line when there's danger, and then people will appreciate your leadership. And you think about the influence that Nelson Mandela has had through the examples that he set of leadership in his life. If only there were more Nelson Mandelas on the global stage. This person you may recognise, the Iron Lady. It's not Meryl Streep, it's Margaret Thatcher. And you know, it's interesting that students would put Margaret Thatcher forward, but of course she was an incredibly powerful leader and a real role model for many women. And she wrote, "What is success? I think it's a mixture of having a flair for the thing that you are doing, and then knowing that that's not enough, that we've got to have hard work and a certain sense of purpose." And I think that's important for those of us who may feel we have a flair for things. You know, you may not necessarily have the impact you want to have without the hard work and without that sense of purpose and bringing other people along. Probably all recognise this young man. You can tell it was taken very early in his presidency because he turned into a silver fox fairly quickly due to the stress of the role. But Barack Obama, he got elected on the basis of talking about change and how change will not come if we wait for some other person or some other time. We are the ones we've been waiting for. We are the change that we seek. Now, Obama was actually paraphrasing Winston Churchill when he talked about change, who himself paraphrased Voltaire, the French philosopher from many, many years earlier. I don't know who Voltaire was paraphrasing, but it's really important. We don't want to sit back and wait for other people to make change. We're the people who can make things happen, and let's do so. And probably the favourite quote that comes through from medical students is this one: with great power comes great responsibility. Does anyone know who said that? Spider-Man? Yep. Well, actually, I've been told by my great nephew, not Spider-Man, Spider-Man's Uncle Ben, said, with great power comes great responsibility. Again, paraphrasing Winston Churchill, paraphrasing Voltaire. So there are lots of things go around. So leadership principles, I think it's important to talk about our role as clinicians, those who are clinicians, in being leaders. And this is a man called William Osler, who the doctors in the room will recognise the name. Osler is regarded as having been the father of modern medicine. He was a Canadian. He set up medical training at Johns Hopkins University in the US, and then he had a chair at the University of Oxford. And as well as being a great clinician and describing a number of conditions for the first time, he was also a great committee person. So he believed in the power of committees, get people together in a room, get them to solve a problem and get them to put forward those problems to make a difference, a bit like we do with our national committees and task forces and so forth. And he wrote down his principles for being a good leader. And here's what he said: always be constructive and courteous. Deflect praise to other people, just like Nelson Mandela. Good things happening, the praise goes out to other people. But shoulder the criticism yourself. Stand up for principle, even in the face of defeat. And don't countenance gossip, which is actually really important as a leader, because if you are in a leadership position, people will talk about what you say, and if what you're saying is bitchy and unkind, that's what will be repeated. And criticise issues and attitudes rather than criticising individuals. But if you do have to criticise individuals, make sure you balance it with any possible commendations. So I actually really like this, and I first saw this early in my career and had it sitting next to me when I was chairing committees, as to here are some of the rules of chairing committees and getting people on board. And meet with your potential adversaries afterwards and in private, rather than having arguments over the meeting table or across the room. Meet with people in private afterwards and have a talk and see if you can find that shared way to the solution that you're both seeking. Now, I wanted to talk a little bit about, I'll come back to this in a moment, about our role for those of us working in higher education and health research. We all have the opportunity to be leaders. I look around the room and I can see lots of leaders here in the room. And we can lead through the influence that we have on the next generation of health professionals and scientists. We can lead through our research contributions, especially where our research has real world implications, which is one of the things I love about the Kirby Institute. What you do impacts people's lives. But we can also use our status as clinicians and scientists and researchers and policymakers and advocates to make a difference. Each of us can follow the example of Michael Kirby, for example, and be an advocate for social justice and human rights, again, very much baked into the Kirby Institute. We can contribute towards ensuring equity of access to healthcare, especially in this country of the fair go, where we pride ourselves on the fair go, but as we know, many people do not get a fair go. We can use our platforms that we have available to us to speak up on what is right. And each of us can stand up for freedom and justice and peace. Because after all, if we don't have freedom and justice and peace, we don't have a healthy society. And each of us can also use our influence to take care of the planet that we live on, as well as the health of our patients, because the two go hand in hand. One way that we can all make a difference is by looking at how we influence our health systems. And I want to talk to you a little bit about health systems. And in doing so, I want to first look at this report from CSIRO and New South Wales Health. I'm not sure if you've seen it, but it's on megatrends in health. Now, a megatrend is a major change that leads to long-term shifts in the way that people work and live their lives. And it comprises forces which have a big impact on government policies. And last year, this report was issued by CSIRO, our National Scientific Research Agency, and New South Wales Health. And they identified 6 megatrends. I just want to share them with you because I think it's important to think about the context of these things in the context of the research work, which a centre like the Kirby does. And the first is around the movement towards limitless care. Now, what does limitless care mean? It means that the traditional way that we deliver healthcare is changing. And we've seen this particularly with the rise of telehealth, with all the benefits that come from it and all the risks that come from telehealth as well. So looking at new models of care, new ways of delivering care, and can we use telehealth in a way that overcomes some of the inequities that we see in our healthcare system? And many of you were very active in advocating when we introduced telehealth in Australia for the whole of the population during the pandemic to make sure that people who needed access to care for reproductive and sexual health were able to get it through the telehealth measures, and they continue. The second is through mass personalisation, and this is our movement towards precision medicine, which continues to expand opportunities to personalise the prediction, the diagnosis, and the treatment of illness. And much of this, I think we're on the wave, or the start of a wave of major change in healthcare with the power of genomics coming into our day-to-day clinical care. And I've got some of the members of my research team here who've been doing some work on exactly that. And how will our health systems use the power of genomics to improve the care we're providing and make it much more precise and personalised for the individual? Augmented care is the use of new technologies. Artificial intelligence has really taken off, and other digital solutions to look at new ways of delivering healthcare, and at the same time looking at equity and safety as major factors to make sure that people are not missing out on these new approaches to delivering healthcare. And then there's the potential for prevention. And I love this one. If I'm remembered for anything as Australia's CMO, I hope it's the CMO who's an advocate for healthy ageing, that we support people to live as healthily as possible for as long as possible. And we look at the power of prevention. And again, genomics will have an impact on prevention because it can help us to target the preventive interventions for all of us. But of course, there are lots of environmental factors which impact on our healthiness as well. And then there's this one, which the Kirby Institute is a major trailblazer on, empowering consumers and engaging communities. And what we've seen, particularly since COVID-19, but also beforehand with the rise of social media, is consumers becoming more empowered and people wanting to have more say in their care and the care of their loved ones. And we're moving towards more health literacy, but at the same time, we need to ensure that there's cultural safety built into what we're doing in empowerment as well. Part of the research which our team is doing is looking at when we engage with consumers, are we just paying lip service to having the consumer voice, or is it a genuine, real voice that is helping to set the direction of the research that we're doing, the policies that we're helping to influence? And the final one is the volatile world that we live in. Of course, we saw this volatility during the COVID-19 pandemic, but the volatility is also there in the environmental factors which are causing outbreaks and global disruptions. Of course, there are other world events taking place which worry us, external factors having an impact on all of us. Now, I'm very fortunate because I was offered 2 years ago to come to UNSW to set up the new International Centre for Future Health Systems, and basically was given a crystal ball and said, look in the crystal ball and think forward 10 years from now on where we would like our health systems to be, and then let's start doing some of the research we need to be doing in order to get there. And part of what I did was, in the first year, was I asked lots of people, including students in the health sciences, about where do you want to see our health system in 10 years or more from now? And these are some of the areas which they came up with, which I'll touch on in a moment. But right at the top of the list was equity, health equity. How do we make sure that the people have access to healthcare and that the outcomes of people's encounters with healthcare are equitable as well? And so we set up the International Centre with funding from the Ian Potter Foundation, matched by the university, to bring together health system researchers from every faculty of this university to work together to tackle future health systems, recognising in this pan-university centre that solutions don't necessarily just rest in the Faculty of Medicine and Health. There are solutions across the breadth of our university, and these are some of the areas of expertise represented in the members of the research team that I've been privileged to put together. And together, bringing together that list of where do we want things in 10 years, we set up 8 aims and 8 areas of work for the centre, which you don't have to copy, but which are around equity, strengthening primary care, transforming our hospitals, digital innovation, the future health workforce, and then external factors on our health systems of climate change, of ageing populations and changing demographics, and the lessons from COVID-19. I just want to talk about each of those very quickly because it is important. Inequities in healthcare and addressing health equity is the #1 global health challenge. Every time any of you go to meetings of the World Health Organization, international meetings, this is what we talk about. The Declaration of Alma Ata had as its aim, way back 40 odd years ago, health for all people by the year 2000. And of course, we got to the year 2000 and we didn't have health for all people, partly because the Declaration of Alma Ata came out in the mid-70s, and a lot of the planning of how we were going to transform health systems was disrupted because of the emergence of the HIV AIDS pandemic at that time and the necessity of putting resources into tackling that particular pandemic. We had another revisit of Alma Ata in 2018 in Astana, back in Kazakhstan, and countries of the world committed to strengthening primary care as a way of delivering universal health coverage. And then we got another pandemic. COVID-19 came along, and a lot of that, again, was forgotten, and we need to remind people, again, of this important focus. Strengthening primary care, no surprise, I'm a big advocate for the importance of primary care, but also to moving health services out into the community as much as we possibly can where people live, and primary care delivered not just by GPs like me, but by the full scope of the multidisciplinary teams that we have available to us, people from nursing and midwifery, from all the allied health professions, consultant specialists, lots of people moving out into primary care. Transforming our hospitals. This is the hospital where I worked during the 4 years before COVID when I was based at the University of Toronto. This is the Women's College Hospital with the famous pink cube, which is where the lecture theatre is. Beautiful building. This was a major downtown teaching hospital. The hospital was 100 years old. They raised it. They built this new hospital. It's now the only downtown teaching hospital in Toronto which has no inpatient beds. It's a hospital with no inpatient beds. Everyone is treated as a day patient. And then if you need care, it's provided to you outreach at home. And there's lots of outreach programs which are running. And it's a wonderful new model of doing things. And when COVID-19 hit, was the ideal place to be providing community-based care to people affected by COVID. Digital innovation, we've all been living through digital innovation, particularly with COVID-19. What I loved during the pandemic was that for the first time, care had to come to patients rather than the other way around. If you think about the way we deliver healthcare, people have to come to the healthcare service. With telehealth, the service came to people. I worry a little bit that we've forgotten about that message because it's very popular with the community in reverting back to old ways of doing things. I'm really excited about some of the digital innovations. When ChatGPT first appeared, now 2 years ago, I was really excited. I thought it was AI for general practitioners. Turns out it was a little bit more than just that, and we're learning about AI. Lovely report from last year, again by the CSIRO, on trends in healthcare, acknowledging the benefits but also the risks. Every time we introduce a new technology, we introduce a new set of risks. And importantly, in this CSIRO report, needing to ensure that AI and other digital health solutions address health inequality rather than contributing to making it worse. And then there's genomics and the power of genomics, which we've been talking about already. This I particularly love is the ability to create a digital twin. And this is doing research not in vivo, in real live people, in vitro, in a test tube, but in silico with a computer simulation. And now you can create a digital twin of you or your patient, and then you can try interventions on your digital twin. And if the intervention kills your digital twin, we know not to try that on you. We'll try something else. We'll move down the line. Catherine North and I have been having a big argument about whether digital twins may actually replace all the people who we're recruiting for trials in the future. She doesn't think that's going to happen. I kind of think it might. And then there's the future health workforce, the people who are a part of working with us. This university, of course, very important for Australia in training so many of our future healthcare workers, and particularly the focus on more interdisciplinary, multidisciplinary, team-based approaches to care rather than solo practitioners working on their own. The change in our demographics, we are a rapidly aging society, as we've kind of alluded already, and this is obviously going to have a big impact on our future health systems. And then there's the volatile world that we live in, and these external factors which have an impact on the work that we're all doing. And finally, COVID-19. And did we learn the lessons from the pandemic? We've had a national inquiry. It's got a whole lot of recommendations. Have we learned those lessons, or are we kind of forgetting what happened and moving forward? Fortunately, we've got some changes happening, which I'll talk to you in just a moment. So I want to talk just a little bit about our 9th strategy and some of the other current initiatives of the Australian government. Australia's 9th National HIV Strategy, I'm sure, Andrew, that makes you feel old because I think we worked on the 3rd and the 4th together a long, long time ago, was launched last year, and its goal is the virtual elimination of HIV transmission in Australia by 2030. And many of you have contributed to this strategy and others in the past. Australia's world-leading response to HIV is marked by strong partnerships with all of you, with people living with HIV, with communities affected by HIV, and with governments, peak bodies like ASHM and NUTSHO and NAPWA and others, community organisations, clinicians, researchers, other scientists, and many more, all working together. And our 9th strategy incorporates and builds on the recommendations of the National HIV Task Force, which was chaired by Minister Butler. Very unusually, the Minister himself attends the meetings and chairs them of his National HIV Task Force. And very important contributions from the Kirby Institute, particularly with Professor Andrew Grulich, with Professor Rebecca Guy, who's spoken there, with Dr. Skye McGregor, who I think has snuck out of the room, and many more. So again, thank you for your contributions as an institute. And there's a strong focus in our national strategy on U equals U, undetectable equals untransmittable. And as CMO, I'm really pleased to confirm that Australia continues to support the comprehensive and innovative approaches to HIV HIV prevention, testing, treatment, and cure and care, rather, that we've been involved with for so long. U equals U should lead us to the magical 95, 95, 95, which of course refers to the UN AIDS global strategy to help end the AIDS epidemic by 2030. Goal of 95% of people with HIV know their status, 95% of those diagnosed are on antiretroviral therapy, 95% of those on antiretroviral therapy have suppressed viral load. I'm sure you can all recite that in your sleep. But I'm a GP. I'm interested in individuals. So I'm not as interested in 95, 95, 95. I'm interested in the 5, 5, 5, the people who are missing out. So it's fine to get up to 95, but it still means 5% of people are missing out. And so how do we make sure that in our goal of achieving virtual elimination of HIV transmission, we don't leave anyone behind? And there have been some great recent achievements, again, many of them led by the Kirby Institute. We've seen a new streamlined process introduced by the Therapeutic Goods Administration to introduce new diagnostic medical devices in Australia. In the last 12 months, we've had 2 new HIV self-testing kits authorised and new point-of-care tests. And again, Kirby Institute very involved in the point-of-care testing work. We've seen greater access to HIV self-tests through the hugely successful mail-out program supported by NAPWA and the national rollout of the Connect program led by Thorn Harbour Health, which happens to be my former employer back in Victoria, back in those days. And we've seen the commencement of the $26 million program to provide access to HIV PrEP for people who are not eligible for Medicare. And New South Wales is one of the first 2 states to have started rolling that out. And we have our program to provide access to HIV treatment for people who are not eligible for Medicare that commenced in June 2023. And recent research, my colleagues here at the Kirby Institute, has found that initiative has significantly reduced the time to treatment initiation among people not eligible for Medicare, demonstrating the impact on that program on improving early HIV care outcomes, reducing treatment access disparities, and lowering the risk of further onward transmission. So again, a great example of what this institute is doing to make a difference in the world and in people's lives. With the changing epidemiology of HIV transmission in Australia, though, we do need to refocus our response. And as you well know, evidence shows us that individuals from overseas backgrounds are more likely to be diagnosed later than people born in Australia, less likely to receive medical care, and less likely to have access to be able to commence treatment. So this is the 5, 5, 5. And last week, Minister Butler chaired a meeting of his task force. Andrew was there again. You're everywhere, Andrew. To review progress, but also to especially discuss this important continuing work with members of culturally and linguistically diverse communities, including recent immigrants, international students, and palm workers. These are the people who are part of the Pacific Island Labour Mobility Scheme, which involves people from 10 of our near neighbours, including countries like Fiji and Papua New Guinea, which have significant HIV outbreaks. We know that the key to tackling this is for us all to work together collaboratively with our sector, as we have done before. And you know, in this particular area with working with cold communities, there's an incredibly diverse range of identities, of beliefs, of values and cultures which reflect our broader Australian society. And we need to work hard to make sure that that diversity is captured in our response and not missing. 2 last things. Last month, the Australian government tabled the legislation to establish the new independent Australian Centre for Disease Control, our ACDC, as we love calling it. And the establishment of the CDC will be a major milestone in strengthening Australia's public health system and especially strengthening our nation's pandemic preparedness for the future. It will ensure that our country has transparent, evidence-based public health agency that's dedicated to preparing us and then protecting us when we have future communicable disease challenges. And I know the Kirby Institute will be very much part of what happens with the CDC. Thank you to all of you for the support you've provided with this. It's currently going through the parliamentary process, and we hope it will open on the 1st of January next year. Not a great day to open something, but there you go. That's when we're starting. And the second thing I want to thank you about is our response to syphilis. My first major act of leadership as the Chief Medical Officer on the 7th of August was to declare syphilis as a communicable disease incident of national significance. And the reason for doing so is because it is totally unacceptable that babies are continuing to die from congenital syphilis in a wealthy country like Australia, and that many of those babies are the children of mothers who are Aboriginal and Torres Strait Islander people living in remote parts of this country. Thank you for the work you're doing. SEDINS is a communicable disease incident that requires national policy, interventions and public messaging. There's been 3 other SEDINS announced in Australia in the last 5 years. Those of you who are doing your public health training, what were they? COVID-19, Mpox and Japanese encephalitis. But this is the first one involving a established infectious disease that's out there in the community. But the notifications are rising. I had to put at least one chart in my slides because this is the Kirby Institute, and every talk has slides. But this is showing the rise and the tragedy that since 2016, prior to that, we were not seeing congenital syphilis being reported in Australia, and then it suddenly started occurring, and we've had 110 cases reported, and 37 of those children have died. 22 of them were First Nations children. It has to stop. And so part of what we do with the SEDINS is we have a national syphilis response plan, which now goes into turbo drive. We have increased cross-sector engagement with all the different health professional groups and community groups who are working with us on raising awareness among healthcare workers. We're particularly raising awareness about the importance of antenatal care because some of the what's driving the congenital syphilis is a lack of access to antenatal care, and therefore a lack of access to testing. We're now recommending 3 tests for syphilis through pregnancy for every pregnant person in Australia. And here's some of the things that we're currently doing and some of the organisations which are supporting us with campaigns around the syphilis SEDINS. So that's where I want to stop, but I want to leave you with the words of another medical leader. Anyone know who this particular person with a great moustache is? No one? John Calder? Do you know who that is? Okay, this is Dr. Albert Schweitzer. And anyone heard of Albert Schweitzer? John, good, thank you. And Freddie, thank you. So Albert Schweitzer was the first medical doctor to be awarded the Nobel Peace Prize back in 1952. And he received the Nobel Peace Prize for 2 reasons. One was for his tireless humanitarian work. He moved from Europe and he helped to set up hospitals in West Africa, many of which later on became major centres for treating people with HIV AIDS, and also for his writings about the reverence for life. He lived through World War II. He saw the atrocities often carried out by medical practitioners and other health professionals during World War II, and he wrote about how this must never occur again and talked about reverence for human life. And as a result, he was awarded the Nobel Peace Prize. In a lecture to graduating medical students, he said this. He said, "I don't know what your destiny will be, but there's one thing I do know. The only ones among you who will be really happy are those who have sought and found how to serve." And I choose to finish with this quote as a final tribute to Brett Tindall, who provided us with an example of someone who found how to serve, and in so doing delivered exceptional service to humanity. And that's what real leadership is about. So thank you for dedicating this annual lecture in Brett's memory, but more important, thank you for ensuring that his service to humanity is celebrated and that his example provides the rest of us with the opportunity to reflect on our own service and what each of us can do to make a real difference. Thanks, everyone.
Thank you, Michael, for a superb talk, wide-ranging, covering a panoply of ideas and exhortations for us all to continue the great work that Brett started here. There is some time for questions. If you're going to ask questions, could you please come to the microphone so the people online can hear? And also, if you're online, you could add questions through the Q&A box there. And I think we already have one of those online. So from Catherine O'Connor, who says, great talk. Major STI issue in rural and remote communities relates to ice use. In these communities, limited access to needle and syringe programs.
Really, really important work. Thank you, Kathy. And Kathy, I hope you recognise that discussion that we had in the sidelines of the ASHM conference about palm workers did not go to waste. It's a really important issue, and so is this one. You know, part of our success in tackling HIV/AIDS in Australia was the early adoption of needle syringe programs, and these need to continue, and they need to be widely available. We are unfortunately seeing more use of injectable drugs like methamphetamine occurring in rural and remote areas in Australia, and we need to be working together on tackling that. Important component of that is working really closely with our Aboriginal community-controlled health organisations who do such wonderful work providing culturally appropriate care to their communities.
John, since you had Michael on speed dial.
I'm just trying to remember all those things. I must have been, it's a while ago, but we'll have to have a catch up on to refresh my memory.
I still have the texts on my phone.
Yeah, anyway, I'm glad it was, I hope it wasn't too painful a memory. You alluded at one point, Michael, to, first of all, thanks for a fantastic talk. You alluded at one point to the review of the pandemic, and you expressed a slightly, I don't know, a slightly concerned view about all those recommendations, and will they be actually considered and brought to fruition. So the one area that I think that was recognised both by that review and by a number of people is maybe the incomplete interface between research and the policy making process, and I think that was a particularly important aspect of that review. In your role now, you're ideally placed to make sure that is that recommendation is heeded, and I wonder how you can encourage us, or how we should try to help make that happen.
Yeah, no, thanks, John. One of the important elements of Australia's COVID-19 response was that we tried as much as possible to have evidence-based policy. So evidence driving policy where the evidence was available. Now, remembering with when COVID started rolling out, we were learning as we went along. But one of the initiatives that Greg Hunt, as Health Minister, got me to do as Deputy CMO was to set up with Sharon Lewin, the National COVID-19 Health and Research Advisory Committee, which was looking at areas that we needed to be doing research into, doing rapid reviews, which then informed the policy work of the then Chief Medical Officer, Brendan Murphy, and the Australian Health Protection Principal Committee. As some of you will know, because I've spoken about it here at the Kirby Institute, I have my own research team based in the Health Department, Action Research Team, doing lots of rapid reviews as well to support the policy work we were doing, and we published 40 papers coming out, which is very unusual for government to actually be publishing. So, you know, I hope that culture can continue. But the CDC, I think, offers a great opportunity as well, because it's independent. It's independent of the department, and the Director General role will be incredibly important in the Australian healthcare landscape, and an opportunity, if we get the right person in that role, for them to really embrace the research community around the country.
Except that the CDC has been explicitly, part of its brief is that it can't do research. I think it can respond to research. I think that's the key point that I was trying to raise with you, is that how to make sure that interface is very strong.
Yeah, well, we have the NHMRC, we have the Medical Research Future Fund, we have a lot of money going into research. We need to make sure that among where that investment is taking place, we're investing in the things that really matter. Thank you. another question there from.
So Bridget Hare online is asking, how does general practice go forward in an era of increasing specialisation?
Yeah, thanks, Bridget. So I want to pay tribute to Bridget because she and I worked together in Victoria. So she came from Melbourne, and she was a wonderful colleague during what were really tough times, as you can imagine, working at the coalface with people with HIV in the early 90s. So it's great. I can't see you, Bridget, but great to know that you're there. Primary care, I think, is going to actually increase in its influence. I hope it does, because that's what I've been spending much of my career trying to see happens. And we do have increasing medical specialisation, but some of that specialisation is also occurring in primary care. So you can have specialisation in the community. It doesn't have to be in a big hospital building. It can be out in the community where people are living and working. I guess in my clinical career, HIV and infectious diseases has been part of my subspecialisation as a GP in this field. So I hope it continues to grow. Certainly, you know, when I go to the WHO, the discussion around universal health coverage and the importance of strengthening primary health care is just so fundamental, and you know, every country has signed up to it, not necessarily delivering it.
We might give the final question to Brendan.
Oh, thanks very much. Thank you, Professor Kidd, for an excellent talk. I'm Brendan McMullen. I'm an academic here at the University of New South Wales, a paediatric infectious diseases physician, but also speaking to you as chair of the Australian and New Zealand Paediatric Infectious Diseases Network. And my question to you is about opportunities for joined up care. So I'm also really grateful about declaring a CDINS for syphilis. I totally agree with you that this is a national crisis, and I think some great work on advocacy has already been done. As a pediatric ID physician, however, I find that there are still challenges joining things up. So sharing the data about maternal infection, ensuring that these infants are followed up. So do you think we can rely on sort of data solutions, or are there other things we need to do to join up care? Thanks.
Yeah, no, thank you, Brendan. Well, I mean, we need to be relying on the wonderful clinicians who are providing the care, of course, and we need to be providing opportunities for people to be working together and integrating. Now, digital solutions provide an answer, but the culture is really important as well. One of the nice things about creating the syphilis CDINS is we're bringing into the tent organisations which aren't traditionally part of responding to communicable diseases. So the College of Midwives, the College of Obstetricians and Gynecologists, your college with the paediatricians, but also the sexual health physicians, all engaged. The emergency medicine doctors as well, because you know, we want them doing opportunistic testing when pregnant people come into their settings. So it's bringing in other people to help us think outside the boundaries that we traditionally think within, and looking at new solutions. And I think that part of what you're describing is that need to look beyond how we traditionally do things and look at new ways of doing things, be like Brett and set a new trail. Thank you.
So before we finish, I'd just like to thank everybody who helped put this together, particularly Elaine, Estelle, Sam, and Lucy. And I'd like you all to join with me in thanking Michael again for a really excellent talk that really provides a great honour to Brett. Thanks very much, Michael.